Hi everyone, today I will be discussing about antiarrhythmic drugs. But before we dive into this topic, it is very important to have a basic understanding of the conduction system of the heart and the physiology of cardiac action potential. The antiarrhythmic drugs work by targeting specific ion channels and alters the electrical activity of the heart to regulate its rhythm. So when you know the basic physiology, then you know about the different phases of cardiac action potential and the role of ion channels in generating these action potential. This knowledge will help you to easily comprehend the mechanisms by which antiarrhythmic drugs work. Now let's look at the conduction system of the heart. This system includes the sinus node, which is also known as the sinoatrial node or SA node. Then there are these internodal pathways that carry signals from the sinus node to the atrioventricular node and then to the bundle of His. And then the impulses are conducted to the right and left branches of Purkinje fibers, which spreads the signals throughout the ventricles and causes the heart to contract and pump blood. Now let's look at the SA node. It has specialized cardiac fibers that can automatically generate impulses. Hence, it is the normal pacemaker of the heart. In abnormal cases, the AV node and Purkinje fibers can also generate rhythmic impulses. However, the only difference among the SA node, AV node, and Purkinje fibers as pacemakers is the discharge rate of these impulses. The normal rate of sinus node is 70 to 80 times per minute, whereas for AV node it is 40 to 60 times per minute, and for Purkinje fibers they discharge at 15 to 40 times per minute. So this is the conduction system of the heart. Now let's move on to the cardiac action potential. We will basically go through two different types of action potentials in cardiac muscle cells. The first one is the one that is seen in atrial and ventricular myocytes. These are not capable of generating automatic rhythmicity. The second one is the one that's found in the SA node and AV node, the pacemaker cells, which are capable of generating automatic rhythmicity. Now, the ventricular action potential. Before we go in detail, let's look at the three ion channels that play an important role in cardiac action potential. So we've got the voltage-gated fast sodium channels, the L-type calcium channels, and potassium channels. Now, the fast sodium channels, they remain open for only a brief period of time and closes abruptly. That is, they are capable of fast inactivation. Then we've got the L-type calcium channels. They're slower to open and remain open for a longer period of time compared to the sodium channels. Now, because they open and closes more slowly than other types of calcium channels, they're also called slow calcium channels. And finally, we've got potassium channels. Now, let's look at the diagram showing ventricular action potential. So you've got that resting membrane potential sitting at minus 90 millivolts. Then you can see that initial spike and then that initial repolarization, which is followed by a plateau, and then there is an abrupt repolarization. And these are the different phases of action potential. Phase 4, the resting membrane potential, it is of minus 90 millivolts. Which basically means that at rest there is a negative charge in the inside of the membrane as compared to the outside. This membrane potential is usually maintained by efflux of potassium. And I've drawn these blue arrows showing efflux of potassium out of the cells, and it correlates with phase 4 in the graph above. Phase 0, depolarization. This beginning of action potential is caused by opening of fast sodium channels. This allows sodium ions to enter the cell. Now, because there are more positive ions flowing in, the membrane potential rises. This causes the rapid upstroke as seen here. And the membrane potential reaches to about plus 20 millivolts. But as these are fast sodium channels, they close quickly. So now moving on to phase 1, we've got initial repolarization. So as we can see that fast sodium channels close, so there are no sodium flowing in. At the same time, there are few potassium channels that open, which causes the potassium ions to leave the cell. This causes the cells to repolarize, and that's why we see that initial dip in the action potential. At the same time, the calcium channels open, and we see rapid influx of calcium into the cells, which also causes a decrease in the potassium ion efflux. Hence, an increase in the calcium ion influx and a decrease in potassium efflux maintains the potential, and hence we can see that plateau in the action potential. Now, phase 3 is the rapid repolarization. Here, the calcium channels close and hence causing the calcium influx to stop. At the same time, the potassium channels open, causing potassium to rapidly exit. Hence, this ends the plateau phase and the cell membrane potential returns back to its resting level. Now, let's look at the sinus node action potential. Here, we can see that the resting membrane potential is 60 millivolts as compared to ventricular muscle fibers, which was 90 millivolts. This is because of the naturally leaking sodium channels. These leaky sodium channels are also known as funny channels. And it is because of this that sodium tends to leak to the inside of the cell. This causes the resting membrane potential to slowly rise. This leakiness of sodium causes self-excitation and is responsible for the automatic rhythmicity of these pacemaker cells. And this is represented by phase 4, that is the slow depolarization. And as you can see, the pink lines, they represent the leakiness of sodium into the cell, which correlates with phase 4 in the action potential. Also note that fast sodium channels are blocked or inactivated at this potential. So the fast sodium channels have no role in sinus node action potential as compared to the action potential in ventricular myocytes. Now, phase 0 depolarization. The continuous leakiness of sodium causes the membrane potential to reach a threshold voltage in which the L-type calcium channels become activated. Hence, there is a rapid influx of calcium causing the action potential. And as we know that calcium channels are slower to open and remain open for a longer period of time, the action potential is also slower to develop. Then comes phase 3 repolarization. Now that the L-type calcium channels close, the calcium influx ceases. At the same time, potassium channels open and hence potassium diffuses out. This reduces the intracellular potential back to its negative level of minus 60 millivolts. So after this action potential is over, the potassium channels closes and again the potassium channels leak into the cells so that the entire process begins again. To summarize, so we have discussed about the ventricular and sinus node action potential. Now looking at ventricular action potential, you've got is phase 4, which is the resting membrane potential, which is of minus 90 millivolts. Then you've got phase 0, that is depolarization. It is caused by opening of the voltage-gated fast sodium channels. Then we've got that phase 1, which is the initial repolarization. It is caused by closing of sodium channels and brief opening of potassium channels. And then we've got phase 2, that is the plateau phase, caused by opening of L-type calcium channels and at the same time decreased potassium efflux. Then we've got phase 3 repolarization. It is caused by closing of calcium channels and opening of potassium channels. Then we have got is the sinus node action potential, where we've got phase 4, that is slow depolarization, which is caused by leaky sodium channels that causes sodium to continuously leak into the cells. Then we have got is phase 0 depolarization caused by opening of L-type calcium channels. And finally, we have got phase 3 repolarization, which is caused by closing of these L-type calcium channels and at the same time opening potassium channels, causing the potassium to move out of the cells and bringing the resting membrane potential back to its minus 60 millivolts. That's it for this video. I hope this video helped you understand the basic concepts of action potential in ventricular myocytes and sinus node. Thank you.